Good evening. This is again Professor Nick. This is pediatric cardiology for PA MP board examination. Let's start from the first slide. I forgot to tell you today is now is about 11 p.m. and the date is Thursday, March 3rd, 2022. Let's start with the first slide. Here we have a board review question. 5-year-old boy is on a routine examination by his doctor. The parents state that the boy became short of breath while playing with friends, and he had a bluish hue to his lips when coming back from the play. The boy teacher also said that he found the boy squatting while playing outside during the recess. Which of the following is the most likely diagnosis? A, this is ASD or arterial septal defect. B, PFO or pattern foramen ovale. C, this is HOC or hypertrophic obstructive cardiomyopathy. D, TOF or tetralogy of Fallot. And the last one is E, restrictive cardiomyopathy. Here, the right answer is D, because of the history of exercise intolerance and squatting while playing outside, so-called TED spells, are pathognomonic for tetralogy of Fallot. The remainder of the choices do not present with TED spells, such as squatting during the exercise. All right, let's go to the next slide, number 2. TOF or tetralogy of Fallot. The clinical tip here is that tetralogy of Fallot is the most common cyanotic heart defect in children. The definition and etiology: TOF is condition which is characterized by several characteristics. Number 1 is overriding aorta. Number 2, pulmonary stenosis. Number 3, right ventricular hypertrophy or RVH. And the last one is, because this is tetralogy, VSD or ventricular septal defect. There is involvement of genetic factors and environmental factors in the cause for TOF, and mostly is associated with chromosome 22 deletions. The presentation is usually cyanosis of the lips and extremity. On auscultation, we can hear whole systolic murmur, the best heard in the left lower sternal border. Number 3 is squatting after exercise activities. Causes: the squatting is caused by increased preload and increased systolic vascular resistance. This decrease of the right to left shunting, leading to increased pulmonary blood flow and increased blood oxygen saturation. Let's go to slide number 3. Slide number 3, continue TOF. is diagnostic and treatment. Diagnostic is X-ray, usually shows boot-shaped heart, then decreased pulmonary vascular marking, and the treatment is surgical intervention, is the only one and definitive therapy. There is a clinical tip here, which is that there is only 3 host systolic murmurs for mitral regurg, 1, 2 tricuspid regurg, and 3 ventricular septal defect or VSD. So remember this. And then we have to remember that the most common congenital heart defect in Down syndrome, this is endocardial Cushing defect of atrioventricular canal. So there is mnemonic here. VSDs are common in Down syndrome, trisomy 21, Edwards syndrome, trisomy 18, and Pateau syndrome or trisomy 13. So we can remember like this, a little mnemonic, PED, Pateau, Edwards, Down. And the numbers are 13, 18, 21. Again, PED, 13, 18, 21. From the smallest to the largest. And here is shown on the right lower corner how it presents TOF. We can see here the VSD, the thickening muscle of the right ventricle, the stenotic pulmonary valve, and overriding of the aorta. Let's go to the next slide. Slide number 4. Here we'll discuss transposition of the great vessels, or TOGV. So here the clinical tip is if the tetralogy of Fallot is the most common cyanotic condition in children after the neonatal period, this condition, TOGV, or transposition of the great vessels, is the most common cyanotic lesion during the neonatal period. So the mnemonic is very simple. TOGV is the neonate lesion, cyanotic lesion in neonatal period, and TOF is the most common cyanotic lesion in the after the neonatal period. So the longest is early, the shortest is late. Good memory. So this condition is characterized by an aorta which originates from the right ventricle and pulmonary artery that comes from the left ventricle. So no oxygenation of blood can occur without a PDA, or patent ductus arteriosus, without ASD or arterial septal defect, or VSD, ventricular septal defect. How TOGV is presented? Presents with early and severe cyanosis. Single S2 is heard. Chest X-ray shows an egg on a string. The treatment of this condition is if the neonates have a PDA, they require PGE1 or prostaglandin E1 to keep the ductus open and NSAIDs, especially indomethacin, are contraindicated because they will close the ductus. There is a two-stage surgery needed to correct this condition, and there is a 50% mortality rate. It means that every 1 of 4 will survive the surgeries. On the right lower corner of slide number 4, we'll see different type of pulses and the meaning of it. Pulsus alternans, this is a sign of the left ventricular systolic dysfunction. Pulsus bigeminus is a sign of HOCM, or hypertrophic obstructive cardiomyopathy. Number 3, pulsus bispherins is when you have aortic regurg. Pulsus tardus in parvus, when you have aortic stenosis. Pulsus paradoxus, when you have cardiac tamponade and tension pneumothorax. And pulsus irregular when you have an AFib. So this is the clinical tips. When you see one of these, you need to connect it with the other one. Let's go to the next slide. On the left side of the slide, we'll talk about hypoplastic left heart syndrome. This is a syndrome which consists of the left ventricular hypoplasia, mitral valve atresia, and aortic valve lesions. Clinical presentations: absent peripheral pulses, single S2, increased ventricular right ventricular impulse, and gray color rather than bluish cyanosis. On the picture on the lower corner of the left side, we'll see the healthy heart, and on the right side we'll see HLHS, or hypoplastic left heart syndrome. Let's talk about diagnostic test and treatment. The chest X-ray usually will show a globular-shaped heart with pulmonary edema. Echocardiogram will show is the most accurate diagnostic test, and there is only one treatment. This is 3 separate surgeries or heart transplant. Each surgery carry extremely high mortality. TA, or truncus arteriosus, this is a clinical tip, occur when a single trunk emerges from both right and left ventricles and give rise of all major circulation. So let's talk about TA, or truncus arteriosus. This is on the right upper corner of the slide. We'll see how basically TA presents. Usually the symptoms occur in the first few days of life, and the baby is characterized by severe dyspnea, early and frequent respiratory infection. On exam, you have a single S2 is heard, and there is only one semilunar valve, and a systolic injection murmur is heard because of these valves' leaflets are usually abnormal in functioning. Peripheral pulses are bounding. The diagnostic tests for this condition: chest X-ray usually will show cardiomegaly with increased pulmonary marking, and the treatment is the point. The most severe sequela of this condition is pulmonary hypertension, which will develop within 4 months. Surgery must be completed early to prevent pulmonary hypertension. Let's go to the next slide, slide number 6. Here we'll discuss TAPVR, long name, which means total anomalous pulmonary vein return. In this congenital condition, there is no venous return between the pulmonary veins and left atrium. Oxygenated blood instead returns to superior vena cava. There is 2 forms, with and without obstruction of the venous return. Obstruction refers to the angle at which the veins enter the sinus. And here, let's talk, in this slide, let's discuss cyanotic lesions. Up to this present moment, we discuss cyanotic lesions. We have a table. Oh, by the way, on the right lower side, we have a table for this condition, TAPVR, with and without obstruction. And we have signs and symptoms, diagnostic tests, and treatment. And we have 2 options, with and without obstruction. Number 1 is with, and number 2 is without obstruction. So, for signs and symptoms of the first one, it's early in life with respiratory distress and severe cyanosis. This is the way how the child is presented. Diagnostic test of this condition is chest X-ray shows pulmonary edema. Echo is the most definitive test, and surgery is the most definitive choice of treatment. Let's talk about TAPVR without obstruction. The first signs and symptoms are shown by age 1 and 2 years old with right heart failure and tachypnea. Chest X-ray, diagnostically, chest X-ray shows snowman or figure of 8 sign. The most accurate test, this is echocardiogram. But is diagnosed with echocardiogram, not by X-ray. And the treatment is the surgical intervention is to restore proper blood flow. Okay, so let's talk about cyanotic lesions. We have a sample question. 3 months, let's go over the question. We have 3 months old female infant brought in the office because of the parent says that will not eat anymore. Upon physical examination, a loud pansystolic murmur is presented or appreciated. The child also appears small for her age, but her record shows no material maternal or delivery complications. The question here is, which of the following is the most likely finding on EKG? A, right ventricular hypertrophy. B, right bundle branch block. C, ST segment elevation. D, QT interval elongation. And E, P-wave inversion. . And the right answer here is A. And this is because of the key in this case is understanding that a child who has otherwise healthy but presented with whole systolic murmur and symptoms of heart failure to thrive most likely has a VSD. Right ventricular hypertrophy occurs when the blood shunting from the high pressure in the left system go to a low pressure in the right system. This could lead later on for ES or Eisenmenger syndrome. ES is defined as a process in which left to right shunt caused by VSD reverses into right to left shunt due to hypertrophy of the right ventricle. Let's go to the next slide. Next slide, we have here very nice pictures of VSD, murmurs, and auscultations. And we have some clinical notes. PDA means patterned ductus arteriosus. TAPVR means total anomalous pulmonary venous return. TJV means transposition of the great vessels, and VSD means ventricular septal defect. And we have here the auscultation sites for aortic, pulmonary, tricuspid, and mitral valves. So we have a summary of the cyanotic heart defects table on the right side of the slide number 7. Tetralogy of Fallot presents with right to left shunt. There is no PDA dependency. VSD is presented, and surgery is necessary as a definitive treatment of choice. TGV, or transposition of the great vessels. We have right to left shunt, yes. We have PDA dependency, yes. We don't have VSD, and surgery is the definitive choice of treatment. For hypoplastic left heart syndrome, we have a right to left shunt, yes. We have PDA dependency, yes. We don't have VSD, and surgery is the treatment of choice. For truncus arteriosus, we have right to left shunt. We don't have PDA dependency. We have VSD, yes, and surgery is the treatment of choice. And for the last one, this is TAPVR, or total anomalous pulmonary vein return. We have right to left shunt, no PDA dependency, no VSD, and surgery is the definitive treatment of choice. Let's go to slide number 8. Slide number 8, we talk about we discuss ventricular septal defect, and this is the most common congenital heart lesion. On the right upper corner of the slide, we can see a very nice picture of the VSD animation, actually. So let's go and discuss presentation. Usually the patient presents with dyspnea, with respiratory distress, a high-pitched hollow systolic murmur over a lower left sternum border, and loud pulmonic S2. Diagnosis is usually by chest X-ray, which shows increased vascular marking. Echocardiogram is diagnostic, and the best diagnostic test and definitive test, this is cardiac catheterization. And the treatment is the following. Small lesions usually closed by age of 1 or 2 years of age, while large or more symptomatic lesion requires surgical intervention. Diuretics and digoxin can be used for more conservative treatment, and if left untreated, complication can lead to CHF, congestive heart failure, endocarditis, and pulmonary hypertension. And we have a clinical tip here. Pansystolic murmur, this is equal to whole systolic murmur, and this means that it's heard on auscultation throughout the systole. Same slide number 8. On the right side we have a clinical question, and let's go over that. We have a 17-year boy which just flew from Australia and landed in New York. Wow. And landed in New York and presents in the local ED with facial drooping, outer metastasis, and left-sided paralysis. He took some diphenhydramine or to get through the flight, is to make him drowsy. And on a physical exam, we reveal swollen left calf muscle. The question here is, which of the following is the most likely process underlying this patient's stroke? A, emboli from his carotid artery. B, emboli from his middle cerebral artery. C, trauma brain injury. D, paradoxal emboli from deep leg vein. And E, medication side effect. The correct answer here is D. Patient most likely has thrown a clot to his brain. The clot was formed in the setting of the venous stasis, and patient was able to travel to his brain, and the clot was able to travel to his brain via a patent ASD. Without the ASD, the clot would have to be embolized to the pulmonary circulation. Choices A and B are incorrect because of the kid is too young for such advanced vascular disease. C is incorrect because there is no history of trauma. Diphenhydramine does not cause emboli. Ruling out choice E. So the right answer here is B. Let's go to the next slide. And here we'll discuss ASD, or arterial septal defect. ASD is a hole in the septum between the both atria, which is twice as common in women than men. There is here 3 types of ASD. ASD type 1, which is concomitant valvular with mitral valve abnormality. ASD type 2, which is most common and located in the center of a atrial septum, and situs venosus defect, which is less common. How this and the right upper corner, we have a very good animation of ASD. Let's talk about the clinical presentation and then we'll discuss diagnosis. Patients are usually asymptomatic except with the fixed wide splitting of S2. The most common test is cardiac catheterization. However, echocardiography is less invasive and can be just as effective and much better than chest X-ray, which shows increased vascular marking and cardiomegaly. The treatment is that vast majority of cases close spontaneously, and surgery or transcatheter closure is indicated only in symptomatic patients. Dysarrhythmias or possible paradoxal emboli from DVT later in life. Let's go and discuss slide number 10. In slide number 10, we'll talk about PDA or patent ductus arteriosus. PDA is defined as a failure of spontaneous closure of the ductus, usually closed when PO2 raises above 50 millimeter of mercury. Low PO2 can be caused by pulmonary compromise due to prematurity. And we have here a clinical tip. PDA is normal finding in the first 12 hours of life. After 24 hours is considered pathological. And here there is another clinical summary. The mitral lesions, the murmur radiates to the axilla. The tricuspid and pulmonary lesions radiates to the back, and the aortic lesions radiates to the neck. This is where the murmurs propagate. The presentation is usually machinery-like murmur, wide pulse pressure, bounding pulses, and there is a high occurrence of respiratory infection and effective endocarditis in the most common complication later in the child's life. There is diagnostic tests which can be done. This is echocardiography or echo is the best initial test, and then cardiac catheterization is the most accurate test. EKG is only supplemental test which shows LVH, which is left ventricular hypertrophy, secondary to high systemic resistance. The treatment is the following. Give prostaglandin to pop open the PDA and give indomethacin to inhibit popping. All right, that's a good mnemonic. Then we need to say that give indomethacin NSAID inhibits the prostaglandins to close the PDA unless it is needed to live in concurrent conditions such as TOF or tetralogy of Fallot. And we have here a few clinical tips for cardiac X-ray findings. Number one, pear shape. It means pericardial effusion. 2, boot-shaped heart, tetralogy of Fallot. C, jug handle appearance. So primary pulmonary artery hypertension. 4. Tree-like appearance or rib notching. It means coarctation of aorta. Let's go to the next slide, slide number 11. There you go. Coarctation of aorta. This slide we'll talk and discuss coarctation of aorta. This is a congenital narrowing of the aorta in the area of ductus arteriosus and frequently associated with Turner syndrome. Clinical presentation, severe CHF and respiratory distress in the first few months of life. Number A. Number B. Differential pressures and pulses between the upper and lower extremity. And C. Reduced pulses of lower extremity in hypertension of the upper extremity due to narrowing. Let's talk and discuss here diagnostic test and treatment. X-ray shows rib notching and number 3 sign on chest X-ray, and cardiac catheterization is the most accurate test. The primary treatment is surgical resection of the narrowing segment and then balloon dilation if a recurrent stenosis occur. And here on figure on the right upper side of the slide, we can see figure 7.4 that due to increased pressure in the vasculature of the subcostal vessel, the ribs become eroded, leading to notched appearance where the arrows are. And we have here clinical tip. On the exam, the question mentioned a short girl with a web neck, shield chest, straight gonads, horseshoe kidney, and shortened fourth metacarpal. Think about coarctation of the aorta. Okay, we're done with slide number 11. Let's go to slide 12. Here we have a sample question. Actually, 2 sample questions. No, 1 sample question with 2 answers. 2 questions and 2 answers, sorry. And this is all related to coarctation of the aorta. We have a 12 years old boy brought by the mother after she found him unconscious. He quickly awoke on the ride to the hospital and was without confusion. The mother states that he did not lose urinary continence and there will be no episodes of shaking. He has had hearing loss since birth. His uncle died suddenly from heart condition. The boy blood pressure is 123/75 and the pulse rate is 76. His mucous membrane are wet and his blood pressure does not change with standing. All right. Now the first question is, what is the most likely diagnosis? We'll go over a few options. A. Seizures. B. Long QT syndrome. C. Orthostatic hypotension. D. Stroke. E. Vertigo. The right answer here is B. And the explanation here is the combination of hearing loss, syncope, normal vital signs and physical exam, and the family history of sudden cardiac death is consistent with long QT syndrome. And the second question is, what is the best initial treatment of this patient? A. Procainamide. B. Verapamil. C. Dronedarone. D. Amiodarone. E. Metoprolol. The correct answer here is E, and the explanation is the best treatment for long QT syndrome is beta blockers such as metoprolol. Beta blockers can shorten the QT interval by decreased activation from the left stellate ganglion and reduce of the cardiac excitation during exertion. If the child has symptoms while the child is on beta blocker, then a pacemaker with implantable cardioverter defibrillator capability may be indicated. Let's go to the last slide. Rheumatic fever. Rheumatic fever is an autoimmune disease which results from untreated pharyngeal streptococcal infection and caused by cross-reaction between streptococcal antigen and antigen of joint and heart tissue. Rheumatic heart disease, or RHD, is possible long-term consequences of the rheumatic fever. While RHD can involve any heart valve, mitral stenosis is the most common outcome. And there is so-called Jones criteria for diagnosis of rheumatic fever. A patient which is positive for rheumatic fever from two of the major criteria or one major plus two minor are presented, along with evidence of streptococcal infection such as elevated and rising anti-streptolizine O titer or DNASE. So here we have Jones criteria described. Major criteria includes migratory polyarteritis, carditis, myocarditis and pericarditis, erythema marginatum, subcutaneous nodules, and chorea. And the minor criteria includes fevers, ascended strep infection, arthralgia, elevated ESR, and prolonged PR interval. And on the right upper corner we see a beautiful girl which the medical provider or the nurse checked the temperature of the child. And the treatment of rheumatic fever is with antibiotics, which the goal is to eradicate group A strep bacteria. Patients with mitral valve disease from rheumatic fever should be receiving chronic penicillin therapy to reduce the risk of group A strep pharyngitis, recurrence, and progression to rheumatic heart disease. The control of the inflammation is with NSAIDs or steroids. And this is the end of my lecture. It took exactly 44 minutes and 30 seconds. Thank you so much.